Waterborne illnesses are among the leading causes of preventable mortality and morbidity amongst displaced people. Safe water is essential for preventing these illnesses, and we as humanitarian responders have technical guidelines to help us deliver that safe water to people. But do they work, and could we do better? In the presentation today, I want to tell you a bit about the work that we're doing to help ensure water is safe in humanitarian emergencies and that public health is protected. And I'm giving this presentation on behalf of an amazing group of collaborators at MSF-OCA and at the Dadla Institute for Global Health Research in Toronto, Canada. So let me tell you where this story begins. In Mabon County, South Sudan in 2012 and 2013, MSF responded to a major refugee crisis. The Mabon County camps were overwhelmed, underserviced, and faced multiple outbreaks of waterborne illnesses. I worked there as a water sanitation specialist with MSF at the time. This is an image of the hepatitis E isolation ward in the Batil camp. Hepatitis E is a vicious disease, waterborne illness, for which there's no cure. All we can do medically is offer supportive care. In the general population in these camps, the crew fatality rate was around 2 or 3%. But for some reason, for women who are pregnant in their second or third trimester, the case fatality rate jumped to 20%. That meant that every time we had a case come in, a pregnant woman come in, we often had 2 deaths because the child would either pass away in utero or would be delivered so prematurely they had very slim chances for survival. This was incredibly difficult for the entire MSF team to witness in the field. And what it did was firm our resolve to break the transmission of the disease in the community. Hepatitis E is a waterborne illness, so we had to break its transmission through the environment through water sanitation and hygiene wash services. So we work with UNHCR and Oxfam and other agencies in the camp to improve the level of wash services and break the transmission, and eventually we were able to do that. Now, one of the things that we were working on in the camp was improving water treatments and water safety. To do this, we were guided by core technical guidelines used by humanitarian responders the world over on how to chlorinate water, to first disinfect it, and then to have some residual protection. The SPHERE project guidelines, the MSF guidelines, UNHCR, Oxfam, all these guidelines generally say the same thing, that free residual chlorine, or FRC for short, at camp water distribution points should be between 0.2 and 0.5 milligrams per liter at camp tap stands, or elevated during outbreaks or when the water pH is attributed as high. Now, we were implementing these guidelines, and even when we achieved them at tap stands, when we went to people's homes and tested the water there, we very often found there was no residual chlorine protection. Other groups of researchers came into the Mabon camps and they found evidence of fecal contamination in household store water, all in the midst of a major waterborne disease outbreak. So this was massively concerning for us. We started to do some digging on the guidelines. And when we did, we found that these FRC standards used around the world in humanitarian response are not actually based on direct field evidence for humanitarian settings. Instead, they come from conventions for municipal pipe water systems in cities. So no wonder they didn't work so well in refugee camps. Now, we shared our concerns about the FRC guidance as we observed in South Sudan in an article of the Bulletin of the World Health Organization. And as we continued to dig into it, we found a lot of reports of water being recontaminated after distribution, contributing to the spread of waterborne illnesses in camp settings. Now, in response to this, we launched work to develop the first evidence-based guidelines for water chlorination in emergencies. We carried out a large multi-site study in refugee camps in South Sudan, Jordan, Rwanda, and Tanzania. And we generated a new set of evidence-based FRC targets that are appropriate for different temperature and environmental conditions. This is work that we previously presented at MSF Sci Days. You can find the FRC guidance document by scanning the QR code on your screen with your phone. There was a lingering problem, however, with the new guidance of external validity. The guidance was based on evidence from 4 specific field sites. We didn't know for sure if they would work elsewhere. We would have to do more and more studies to prove and demonstrate they would work everywhere. Whether they work in Bangladesh or in Yemen or Nigeria, we just didn't know yet. But this got us thinking. Humanitarian agencies are regularly collecting water quality monitoring data in every refugee and IDP camp, water supply project around the world. Mostly this data just gets used for reporting purposes, but there's potentially life-preserving information inside of that data. Now, we had developed some pretty advanced data analytics as part of the earlier research when we developed those FRC guidelines. And we realized that if we could put those analytics up on the internet, on the cloud, field workers anywhere in the world could upload their routine water quality monitoring data to the cloud and then use that data to generate a custom, site-specific, and evidence-based FRC target that is demonstrated to ensure water safety at households where people actually drink water. And with that, the Safe Water Optimization tool was born. So here's how the SWOT, as we like to call it for short, works. First, field workers collect paired water quality data, meaning first from the tap stand, the water distribution point, and then from the household, the same unit of water, after the usual duration the water is stored and used in that particular camp setting. Step 2, they use the SWOT's web platform to upload their data to the cloud. Step 3, that data is used to train the SWOT's analytical algorithms, which generate a recommendation on how much FRC must be at tap stands in order to ensure that water is safe at households for the entire duration of storage and use at that particular setting. The SWOT is built on 2 analytical engines that help unlock that life-preserving information inside of the monitoring data. One of these is a machine learning engine, which uses artificial neural networks, a type of supervised learning AI that mimics the structure of a neuron in which a set of inputs are mapped to a set of outputs and a predictive model is built. The second is a numerical modeling engine that is based on engineering optimization principles. Here we use the raw field data, so the chlorine decay data, water quality and time data, to solve the general integrated rate law, a fundamental law from chemistry that tells us how fast the concentration of a chemical species is changing over time as it undergoes reactions. This modeling allows us to predict the FRC at different times under the prevailing decay conditions represented in the site data. Now, all the analytics and software development work that we have done for this work, for this project, is open source and available on GitHub. Based on the outputs from the 2 analytical engines, the SWOT issues a recommendation on what FRC must be at tap stands in order to ensure that there's at least 0.2 milligrams per liter at households at the maximum duration of household storage and use. Now, that 0.2 milligrams per liter is very important because evidence shows that waterborne pathogens, fecal bacteria, cannot exist in water that has at least 0.2 milligram per liter of FRC. That's why we need to have that much to ensure the water is safe to drink. This recommendation is delivered to field workers via email. Those field workers then implement the SWOT FRC recommendation and continue to monitor water quality data and upload it to the SWOT. The SWOT then learns from the new data coming in and adjusts and adapts the FRC target as conditions change in the field. Now, once we built the SWOT, we set out to evaluate its effectiveness for ensuring household water safety through a proof of concept study at Kutupalong, Bolakali in Bangladesh, a massive refugee settlement hosting around 1 million Rohingya people who have fled neighboring Myanmar. At Kutupalong, MSF was carrying out medical and water sanitation activities, including operating water supply systems in multiple parts of the camp. We selected Camp 1 in the northwest sector of Kutupalong, where MSF operated a water supply system serving 83,000 people. Now, across the 10 networks in Camp 1, we measured 3 water quality parameters directly from water leaving the tap: FRC, water temperature, and electrical conductivity. Once users have collected the water at the tap stand, we then accompany them back to their households where we mark that container of water. We then return to the same household after 4 to 18 hours of household storage and use and tested FRC again from that same container from the same water. Now, between July and December, we collected over 2,000 paired observations following this protocol. We used data from July to September to train the SWOT's analytical algorithms and generate a site-specific water chlorination target. And we then used data from October to December to evaluate how effective that SWOT FRC recommendation was compared to the status quo SPHERE guideline for FRC for ensuring household water safety. At the same time, we conducted a rapid CAP survey in the camp, so a knowledge, attitudes, and practice survey to gather contextual data to explain the site of our pilot, including, most importantly, the typical maximum length of time that water is stored and used in households at that site. We obtained 3 levels of ethical approval for this work from the MSF ERB, the York University Ethics Review Board, and a local ethical review committee in Bangladesh. Now, from the CAP survey, we learned that the maximum length of time that water is stored and used in households was around 15 hours. The SWOT generated a recommendation for FRC at tap stands that it should be between 0.8 and 1 milligram per liter in order to ensure that the 0.2 milligrams per liter at 15 hours post-distribution. We evaluated how effective the SWOT FRC recommendation was compared to the status quo SPHERE guideline by assessing the proportion of household samples that exceeded the 0.2 milligram per liter threshold at follow-up when upstream FRC, tap stand FRC was in line with either the SPHERE recommendation or the SWOT recommendation. Top line finding was that the SPHERE recommendation yielded safe water in 43% of sampled households at 15 hours post-distribution. In comparison, the SWOT recommendation yielded safe water in 85% of sampled households 15 hours later. What this showed us was that implementing the SWOT recommendation at tap stands would nearly double the proportion of households with safe water at the Bangladesh pilot site. Now, one of the major concerns that comes up around chlorinated water, particularly when we talk about increasing the level, is taste and odor-driven rejection of water. So we did some digging on this as well through the CAP survey. We found that about 80% of respondents reported no concerns with the taste of water. A minority of about 10% had issues with the taste and odor of chlorinated water. Now, this represents a generally high level of acceptance of chlorinated water in this population, and it coheres with other research in Bangladesh that shows that people can accept chlorinated water up to 1.25 milligrams per liter. So we're working well within those acceptability limits with the SWOT recommendation. So what did we find in the end? The Bangladesh pilot showed us that the SWOT FRC recommendation outperforms SPHERE guidelines for ensuring household water safety. By improving household water safety, the SWOT has the potential to yield public health benefits and to improve monitoring, reporting, and accountability for water safety to populations and to donors. The SWOT is now ready to go. Our beta is live. You can check it out at that link in the top right corner of the screen. You can request a field trial, and we are ready to support field users in implementing and training their staff to use the SWOT. Right now, we have field trials underway in Nigeria with MSF and in Tanzania with UNHCR and NRC, and shortly additional field trials with MEDAIR and other agencies as well. Our next steps in growing the SWOT are to diversify its applications to other water supply use cases in humanitarian response, including surface water sites, water trucking, medical facilities, as well as intermittent water systems in non-emergency settings. Now, I mentioned earlier the chlorine taste odor issue. Now, that's a concern. This represents an upper limit to chlorination practice. So we want to develop rapid protocols for evaluating quickly in any field site what is that chlorine taste odor rejection threshold, so we can be within those limitations. We also want to develop rapid protocols for assessing disinfection byproducts. These two things represent important upper limits to chlorination practice, so we want to integrate these into the SWOT. Taken together, all of these tools form part of an integrated SWOT toolkit for advancing effective and acceptable safe water practice in humanitarian operations. So thank you very much for your attention. To learn more about the SWOT, again, please check out the link in the top right corner of the screen. Our team is standing by to help train and support your teams in implementing the SWOT at your site. We have a number of people to thank without whom this work would not have been possible. First, we'd like to thank the Acmea Foundation for their general financial support for this work. We also want to thank the HQ MSF OCA team, the SWOT steering committee, and the Watson unit advisors in the IT department for all their work in helping us implement this project. We also want to thank the field teams at OCA, MSF OCA, UNHCR, NRC, and BRANC in Nigeria, Tanzania, and Bangladesh for their excellent work on the ground implementing the SWOT. So thank you very much for your attention. I look forward to working with you on implementing the SWOT and improving water safety for the people who need it. Thank you.